to have Dr. Joshua Bales today, who is with the Northwest Orthopaedic. And Dr. Bales has been here since August. And I went quickly, and of course, you know, let's hear it for Google. You can find anything on Google. And it says that Dr. Bales is a fellowship-trained orthopedic surgeon who specializes in hand, wrist, and elbow surgery. And while training at UCLA, he cared for a broad spectrum of patients, from UCLA athletes and children at the Shriners Hospital. And Dr. Bales has contributed to the science of hand surgery through journal articles and presentations at national medical conferences. So I am so very happy and proud to announce Dr. Joshua Bales.
Perfect. Well, thank you for that introduction, and good afternoon. Full house, this is great. Let's talk about some hand stuff. I'm going to try to go quickly but thoroughly through common problems that we encounter in the hand as we all get older. Some happen earlier rather than others, but a lot of stuff that you look down and say, why is my hand doing that? So we're going to jump right in. Now, the hands, obviously I'm biased, is probably the most important part of the body, and you can see it time and time again in the literature and you know, any major novel, and I thought this quote was great to start us off. Often the hands will solve a mystery that the intellect has struggled with in vain. So jumping in, we're going to talk about numbness, pain, clicking. We're going to talk about the different diagnoses that can go along with these problems. And we're also going to talk about treatment. And even though I'm a surgeon, I think a lot of these things can be treated very well conservatively, such as with injections or with bracing. There is no need to make that jump initially to surgery, although that is always an option in the end. And then also try to manage expectations, because a few of these problems, depending on how long they've been going on, can be brought back to normal, or at least can be brought back to kind of normal. Wait for it. All right. So I thought one of the ways that I always learn best in medical school and going forth is kind of categorizing these things into a vignette, into a story, if you will. So we're going to start with our craps player to go first, and a 64-year-old male, and he is catching and locking of the fingers such that he can't fully open up his hand without a pop down in the distal palm, and that really throws off his dice. He says it gets stuck in flexion, and he has to physically pry it open, which is just not pleasant for him at all. And it's also worse in the morning. So this is our chap. We can call him, let's call him Ted. So the most likely diagnosis is trigger finger, and it actually got its name because initially a lot of doctors thought it happened in the index finger, which of course is your trigger, but it's more common in the ring finger. It can happen in any finger. It also can happen in the thumb. And it is worse in the mornings, and what happens is a trigger finger is your flexor tendon, and if you imagine your tendon that brings the finger down like so, it's kind of like a pulley. And if you imagine a knot in one of those pulleys, it's going to get caught as it wraps around there, and that's just what happens in the hand. As it goes down, it comes in, and we're going to get the laser pointer here, and this knot gets locked up in this tunnel right here, and it's very much a mechanical problem. Surprisingly so, you would think that this would always need surgery, but we've looked at thousands of patients, mostly my mentors have, I'm still young in the business, but what we found is we can cure it with an injection. A corticosteroid injection given right here at the base of the finger, and that calms down the inflammation and breaks the cycle so that that finger does not catch or lock nearly as much. Now, people have tried to figure out why does this happen, and to be honest, we don't know. We know that there's association with diabetes, but this can be argued, and in fact, in one of our most recent journal articles, it has been looking at hemoglobin A1C and the incidence of trigger finger. Some people think it's due to repetitive use or trauma, but again, the jury is still out. We know that it is a problem, we know the pathology, we know why it happens, and we have some good tools to treat it. So again, conservative first, and hopefully that'll be a recurring theme. And one of the things when people think about any hand ailment is, can I splint it? And it's a good question. I am not the biggest fan of splinting trigger fingers because the splint keeps the finger up in this position and prevents you from bending at this knuckle right here. And that can be very cumbersome when an injection is something that offers a quick, very comfortable relief. Now when we give the injections, the first one we hit a home run in about 50% of patients. and then I'll wait a couple weeks, sometimes up to 4 weeks, and if it's still giving you a problem and you didn't mind the injection, we'll give another one, and that can catch up to 80 to 90%, and it's that last 10 to 20% that actually need the surgery. The injection is a mixture of steroid and lidocaine. It is not the steroid that gained national media attention for having contaminants. I use a very specific one, and I think a very good one for hand ailments. And it's given in the office. It can be done. It takes about 5 minutes. Now, there are risks, and I trade with old Navy Admiral, and he burned it in my head. Anytime you do anything for a patient, you got to tell them the risks and the benefits. So the injection is very innocuous, not that big a deal, but it can cause a little bit of fat atrophy. Only right here. I've had people ask if it causes fat atrophy elsewhere in the body, but alas. It can also alter your blood sugar. So if you're a diabetic, it's something to pay attention to. A good study came out of University of Utah, and they looked at diabetics who got a trigger finger injection. They followed them out for a week. And at 3 days, there was a peak of how high the blood sugar was, and then at about 5 days, it normalized. So it's just something to keep in mind. If you get one of these injections, we need to be vigilant about that. And the last thing is we are injecting fluid in a tight space. It's nice because it gets washed out within that flexor tendon sheath, but it can cause a little bit of just transient swelling. This becomes more of an important issue when we talk about carpal tunnel later on in the talk. So the surgery, if it comes to that, and most of the time it does not, is one of the simpler surgeries that I do. It's a small incision that is right at the base of the finger here where my thumb is pointing. It's a longitudinal incision, and then we just go down to where the tendon sheath is, where the pulley is, and we release that pulley. And then during the surgery, I call it my interactive surgery. Most of the patients are either fully awake, and we just give a little numbing medicine to the finger, or they've had a little bit of anesthesia so that the numbing medicine doesn't hurt at all. They come to a certain degree, do not feel pain, trust me on that, and I ask them, I was like, can you bend your finger down? So during the surgery, they'll bend, and I can feel the finger and make sure that there's no residual triggering. Because the last thing we would want is, to fail the injections, have to go to surgery, and then have an unsuccessful surgery. So it's kind of a team approach in surgery. Takes 10 minutes, go home the same day. The bandages come off in about 4 days, and then you're back doing activity once I get the stitches out about 10 to 14 days. So any surgery is obviously a big deal, but at least in the spectrum of things, this is a little bit quicker and easier as far as surgeries go. Again, this is the incision right here at the base of the finger, and you can see from the schematic, this is an old Gray's Anatomy text, that we just make a nice incision right here and allow the tendon to get a breath of fresh air. So our goal is to stop the catching and locking and more so give function back. It's very hard, and I've seen folks come into the office literally where their finger is stuck down like this. And that's not what we want anybody to get to, and we want the pain largely to go away. Trigger finger is so common these days that it really should be thought of as one of the first diagnoses. My old medical school professor would say, if you hear hoofbeats in North America, think of a horse before a zebra. So this is common things being common. So if you're having pain down there, it most likely is this, but of course we can talk about it in the office. Our next patient, let's see, I didn't have names for these folks. My best man at my wedding was Brad, so we'll call him Brad. 67-year-old male with thick scar-like tissue in the palm. It's been bothering him for years, and recently the gentleman's noticed that it's starting to pull the fingers into the palm, so much so that when he pushes off from a table, he can't fully straighten out his fingers, and very curious about why this is happening. He also has some thick nodules over the knuckles on top of his hand, which is a curious finding as well. And when you ask him, he says he has no pain, but of course there's limitations in use. And the most frequent complaint I get is people have difficulty when the fingers are cocked down like this to put their hand in their pocket, or if they're right-handed to go and shake somebody's hand. So this patient has what's called Dupuytren's. And this is just a clinical picture of Dupuytren's. You can see this gentleman has a very thick nodule, and this nodule here is called a pretendinous nodule. It gets the name because it's right in front of the tendon in the palm. Now, Dupuytren's can come in many different flavors. You can have this type. You can also have cords in between the fingers. You can have a cord over here by the thumb. The thumb cord is actually called Grappau's cord. And no one knows why this happens, why is it accelerated, and really what to do about it. It has a scary name, but it is not a malignancy. It's not a cancer. It goes nowhere else in the body. But it does have associated problems. You can have this in the foot. You can also have this in the back of the knuckles, where you get these very thick knuckle pads. And in gentlemen, it also can occur in the penis, which is called Peyronie's disease. So it's one of the few patients that urologist and I, we have the same type of patients. And what it is the layer right below the skin gets confused and forms scar-like contracture. It is much, 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 much more common in Caucasian males of Scandinavian descent, and we don't know why. We're trying to find the exact gene of it right now, but it is multifactorial. The other question that comes up with this, and we don't know the answer to, but we have inklings, is, well, I have a little bit of this thick stuff in my hand. Is it going to get worse? And that really is the million-dollar question, because we don't know. The one thing that we do know about Dupuytren's is it's accelerated by trauma. Sometimes trauma that I create. So if you have a trigger finger, let's say on the second digit here, and we release that, any trauma in the hand can accelerate the scar-like tissue and make it really kind of go crazy and pull the finger down more. It can also occur with an injury, such as a fall. But you know, I think this disease has been misunderstood and continues to be misunderstood. Back in the day, I thought this was associated with alcoholism, but that has been dispelled. That's what I was told when I went through medical school, but it does not fit the picture at all. So when to see me about it? You know, everybody has some calluses in the hands and some thick tissue down there. What I tell folks that come to me for other reasons and ask the question is, whenever you come to the point where you cannot put your hand flat on a table, it's the so-called tabletop test, then come in and we can at least chat about it. It's one of the longer clinic visits I have because we have a bunch of different ways to treat it. And what are the treatments? So there's 3 main treatments for Dupuytren's disease. Actually, I should say 4. You should always start conservatively. There's no reason to jump into surgery, but if it is affecting your activities of daily living, there are 3 things we can do. One is the old tried and true method, which is called an open treatment, where we make a larger incision within the palm and take out the diseased tissue. I didn't want to put too many graphic images in there, but it is amazing how, when you're inside the hand, how discrete this tissue is. It is thick, it is white, and it looks nothing like what surrounds it in the hand. The other treatment is to go in, and I'm going to back up a little bit. The other treatment is to do what's called a needle aponeurotomy, where I take a small needle and I numb up the top of your skin, and I basically make nicks in this cord. And if you think about a rope that's tethered from here down to here, with enough nicks, that cord will break and the finger will be quote-unquote normal again. The last treatment, and this received FDA approval probably 6 years ago. Where I trained at UCLA, they were doing it before that because they were part of the initial research trial. And this treatment is called Xiaflex, or it's a collagenase. And it's a specific enzyme that's injected that digests the cord and cord-like material. It's kind of like Botox, for lack of a better example. So this is just showing kind of the incision that would be made for the open surgery. Instead of making a straight incision, we have to make what's called Z or Brunner incisions within the hand, because if you make a straight incision in the hand and just close it normally, it will scar down, and this is even in a normal adult. Next is the needle, where we kind of spot dose here and here. And then the last treatment would be the Xiaflex treatment, and this is off their company website. Basically, the Xiaflex acts on this cord and has straightened it out after treatment. What you do is you give the Xiaflex on day 1, and then within 24 to 48 hours you come back and you manipulate the finger, and the cord literally breaks apart. Now, each of them have drawbacks. Let's see, the goal is to get straight fingers and minimize recurrences. And as you can imagine, drawbacks are this: if you are doing open surgery, you've got the whole disease out of there. Recurrence risk very, very low. 5-year recurrence risk somewhere between 10 to 20%. problems with the open surgery. It's a lot of rehab. You got to heal that wound. You got to keep the hand straight as possible while it's healing so you don't develop any contractures. And you have to worry about injury to adjacent structures like nerves, tendons, and so forth. When you do the needle, this is a surgery that's pioneered down in Florida in the States. It started in France, but Charlie Eaton did it there, and then it went over to California and a few other places. It's a good surgery. It always makes me nervous. I take a few blood pressure meds, runs in the family. I take a few more when I do this surgery because it's a blind surgery. I'm talking with you the entire time and asking you, do you feel anything going down your fingers? Because I'm trying to go in and just gently lice or break apart that cord, knowing that there are two digital nerves on either side of that cord that just really don't want to be irritated. So we're going through it. It's a very good surgery. I've had great results, minimal recurrence, but it's something where you have to be awake for, and some folks don't like that. The last one is the collagenase, which when it came out, it was supposed to be the next best thing since canned beer. It really was. I got calls. I went to undergrad school where I'd say 80% went to Wall Street. Didn't hear from these guys at all. Once they found out I was a hand surgeon and this came out, Dr. Bales said, should we invest in this? Should we do it now? Because it was really touted and advertised more than any other thing we've ever seen in hand surgery. And it's good. It digests the cord. It's anywhere from $2,000 to $5,000 a pop. It can only do one cord at a time. And if you've seen or had friends with Dupuytren's disease, most of the time it's in a bunch of different fingers and then it's in a bunch of different cords. So you need the right patient for collagenase to work. And at $2,000 a pop, even Medicare won't do it for more than a few cords. So that becomes something where we think about the open surgery. But it's something on the table. My biggest concern with it, and this is plus minus, is the fact that if it's injected too deep, it likes to eat collagen. It eats the collagen that causes the contracture. It will also eat the collagen that's made in part of your flexor tendon. So the 4 complications that they've had have been flexor tendon injuries, which you don't get back. There's when you cut the tendons in the palm, you can repair them. When they're injured by Xiaflex, they're digested. So you need actually to do a 2-stage approach to get that tendon back. And that complication has scared me to a large degree. I still do it, but again, I think each of these surgeries needs the right patient. So that's why it's one of the longer clinic visits that I have with folks. The next vignette, this is the one we're going to spend the lion's share of the topic on, is a 57-year-old female who comes in and complains of pins and needles, mostly in her thumb, some in the index finger and the middle finger. It'll wake her at night and she'll have to wake up and shake the hand out because the pain is so severe. When talking with her, she has a medical history for diabetes and hypothyroidism. Anybody know what she has? Yeah, she has carpal tunnel syndrome. Perhaps the number one thing that I see in the office, just right in front of trigger finger. So what is carpal tunnel syndrome? All we know about it after years of study and having thousands and thousands of patients that have it is that it's pressure on the median nerve within the carpal canal. Is it inflammation? Is it repetitive use? Those answers still haven't been sought out. So just to kind of give you a brief idea about pressure, is the normal pressure within the carpal canal, which is where the median nerve rests and where it lives, is about 2.5 millimeters of mercury. When you get your blood pressure checked at the office, they'll pump that cuff up to about 175 millimeters of mercury. And if you guys can guess how in the world we know that 30 millimeters of mercury is where the carpal tunnel says no more, it's because medical students will do anything for a buck. In University of San Diego, they took a bunch of med students and they said, do you want to go into orthopedics? Yes, we want to go into orthopedics. How do you feel about having a WIC catheter placed in your wrist? Here you go. So that's how we know. We had about 20 healthy male volunteers, and they were willing to do this. This was before my time, but I still know the gentleman who made them all do it, and I hold it over his head every day. But we know that 20 millimeters of mercury, that little increase, is all that it takes to cause the median nerve to get angry and for the fingers to go to sleep. And then we know that when these medical students extended their wrist all the way and flexed their wrist all the way, that pressure went up. So one of the first treatments whenever we think about carpal tunnel is to try to keep the wrist in a neutral position, because that is where the pressure is the smallest. That's why so many people out there sleep with wrist splints on, my grandmother being one of them. And that is such a useful tool, because if you can calm the wrist down, at least for nighttime sleeping, most of the time you can beat carpal tunnel. Because no matter how you wake up, everybody sleeps in the fetal position a goodly amount of the evening. So is it common? Oh yeah. 500,000 surgeries per year, $2 billion annually, and this is only an operative cost. So obviously this is something that Medicare looks at very seriously, because should we be doing this amount of surgeries? Is there something else that we can be doing? Is there a safer way? Should we do it endoscopically? Should we do it open? Should we even do surgery at all? Should we control the diabetes better? Is that the problem? So obviously the government, Medicare, everybody's very interested, and you guys as patients, into why this occurs and how do I get rid of it. This is a schematic of where the carpal tunnel is, and as you can see, it is a rock and a hard place. The rock being the bones down here, and all these tendons kind of go along with the median nerve, which is right here, and it's covered in a very thick ligament up here on top that goes from this bone all the way to this bone. The length of the carpal tunnel varies. It is normally about an inch, inch and a half that this median nerve has to transverse. But if you think about it, like a tube carrying water, it only takes a millimeter of an area of very specific compression that's going to block your conduction. So how does it happen? We could do an entire 2-hour talk on this, but I'll try to go briefly into the various theories, and of course we can do questions at the very end. Is it idiopathic, anatomic, systemic, or exertional? So idiopathic is just a fancy word for we don't know. We have no idea. Believe it or not, that was one of the first med school exams. What does idiopathic mean? We know that women are affected more than men, and we know that incidence increases with age. So this is something that, like rotator cuff tears, that as we get older, for whatever reason, either the ligament gets thicker or the nerve, it just isn't as resilient with those changes in pressure. The next thing is anatomic. So pressure is highest right here where the little lightning bolt is, and it is where the ligament is the thickest. So kind of if you think as the nerve is racing through, I'm going to get through this carpal tunnel, I'm going to get through, and then the very last thread, the very last fiber is where the nerve is really pinched in the majority of patients I see right here. They did another study, and this is just interesting how information is disseminated, and they asked residents now, so these are people out of medical school in orthopedics, and the exam was, where would you put your incision to release the carpal tunnel? And even in these residents, it went all over the place. Some were incising up here, some were incising here. The carpal tunnel is actually right in here. It is just a little bit farther. If you look at your own wrist, there's what's called the distal palmar crease right here. It is just beyond that. That is where the carpal tunnel resides. Now, anatomic, well, of course, anything that's in there is going to cause increased pressure. That's our common thing. Pressure causes the problem. So if you have a lipoma, which is a fatty tumor, if you have a cyst, if you have an infection, if you have anything occupying space in there, including a steroid injection given by yours truly, that actually could cause some problems. So we'll get more to steroid injections, but that's why I don't do too many of them in this region. I'll never forget, we did a carpal tunnel release on somebody, and they had no history of gout. We got in there, and there were all these gouty crystals. So anything that causes a mass effect within this small space is going to cause carpal tunnel syndrome. So this is just, kind of showing you a visual here. If I put a big lipoma in the middle there, it's going to displace the median nerve. Now, this, necessarily is not germane to this group right here, because you're all safe, you're sitting, you're relaxed, you were not just involved in a high-speed motor vehicle accident nor an industrial injury. So trauma is not going to be the reason for your carpal tunnel syndrome, but I will tell you that when people have traumatic injuries such as a car accident, if you get enough of a bump right where the carpal tunnel is, you can develop a very acute form of carpal tunnel. And this, unfortunately, is not something where we get to wax poetic in the office about. This is something that should be treated within 6 hours, or it can cause long-lasting nerve deficits. So if you have a family member, heaven forbid, that gets into an accident and says, my fingers, I can't feel them, that they need to talk to me sooner rather than later. And this is just an example. This is my only gory picture. It's in the middle of the talk to wake up those needing waking up. But this is where, if you look here, there is an outline. This patient was operating a die punch, and the die punch hit his hand as opposed to the metal substrate. And it had enough strength where it extruded muscle, so you can bet dollars to donuts he had carpal tunnel, and he did, so we released him. So quickly went beyond it, so now we got everybody back. Again, you need to release it quickly. That's just the take-home point there. So what would be permanent outside of trauma? Let's say you've been struggling with carpal tunnel syndrome for a while. You've had numbness and tingling in your fingers. It's been getting worse. You're starting to drop objects. You have difficulty buttoning your shirt. The numbness can be permanent at a certain point. Most of the time, if it's pressure related, we take the pressure off and everything gets back to at least a little bit more towards normal. You can have weakness of the thumb, and this is something that takes longer. Our bodies were built in such a way that if I have a nerve and I squeeze down on the nerve, the first thing that I lose is going to be motor. The next thing I lose is going to be sensation. The last thing I lose is going to be pain. Isn't that nice? We were built that way, so pain lasts until the bitter end. It is what it is. And then when we take the pressure off, it goes in the reverse order. Pain comes back, sensation comes back, and then motor comes back. Motor coming back anywhere in the body is a function of, well, how long have I been having pressure there? Because the body is very industrious. If you're not using a muscle, it's going to go away. And that timing is about 6 months for a complete block. We don't have all the data on a carpal tunnel type block. So obviously we know it's not doing you any good, but if you're starting to get weaker and weaker, that's when I get a little bit more. I never ever push surgery, but there are times where I'll recommend it a little bit more vigorously than other times. We talked about car accidents. Actually, this is a good time to go back. Autonomic problems, just touching on this briefly, is a rare side effect of carpal tunnel. And normally it's at the very end, and I'll show you a picture of a gentleman who has it at the very end. After you lose motor, your body also has certain sensory capacities that are transmitted along blood vessels. So hands will get blue, or hands will have problems sweating if you injure the nerves along these blood vessels. And this would be another talk. This is the type of thing, I don't know if you've heard of Raynaud's or other vascular problems. This goes along with it, and carpal tunnel does supply some of the nerves that go along with the vessels. So a very late stage finding would be this kind of vascular neuropathy. Alrighty. Oh, busy slide. This is just showing you that systemically there are so many things that could cause carpal tunnel. I tried very hard in the handouts to make all the font 32. This slide just could not be 32. And it's not so you could go in there and check off things. It's just to let you know that, you know, carpal tunnel has been associated with everything from obesity to diabetes to myeloma to scleroderma and the like. And we'll touch a little bit on some of the more common diseases. These are the usual suspects. So diabetes affects the nerve poorly. Anytime that the normal kind of milieu or the blood sugar in the body is too high, it doesn't agree with the nerves, and the nerves are taken down a state because they're not nearly as healthy. So in diabetics, when I talk to folks about doing the surgery, their recovery is not nearly as quick because the nerve is starting at a lower baseline than a normal nerve would be. And this goes the same for patients with thyroid disease, chemotherapy, alcoholism, and kidney disease. The nice thing about alcoholism, if you stop drinking, the nerve comes back a lot quicker than if you are a diabetic and you start controlling your sugars. So, again, we talked about baseline here. You think about diabetes, you think about thyroid disease, your nerve isn't starting at 100%. So when I relieve the pressure on it, it's going to get better. And we have good data showing that it's going to get better. Even one of the better studies was out of Johns Hopkins, and ladies with breast cancer and carpal tunnel were treated with release. And they did get better. They noticed a decrease in night symptoms and a decrease in pain. And sometimes, if you give a patient that, I've found that that is just worlds better than where they're at. You know, they're okay with numbness, they're okay with a little bit of weakness, but the constant pain associated with carpal tunnel can be very debilitating. So, the other thing, and I feel horribly about this, I have a few patients that I see as they're pregnant that have carpal tunnel syndrome, and it is just the pits. It is painful, it causes numbness, a lot of waking up at night, as if pregnant ladies didn't need that on top of everything else. And now they have carpal tunnel syndrome. The nice thing is that even we don't know the cause, we know that it goes away after the birth. Now the treatment for it, when you talk to friends and family, is difficult, because most of the time I just give these folks splinting. Obviously with a baby inside the belly, I don't want to give a steroid injection. It's supposed to be innocuous, but I always want to err on, more cautious. And surgery during this is a very big no-no. It's not worth the risk at all. There are some people that I see and have been recommended to in the past that, if you get this during pregnancy and it is absolutely awful, then maybe before you get pregnant again, we can go in and take care of the problem. Now, this is a little bit of the drama, and this slide actually comes from a talk when I was talking to workers in kind of a workers' compensation style arena. And it's difficult. It's difficult to say that this does or does not occur with repetitive use. There are people who argue that it does. Now, we've done randomized studies showing that there is not sufficient evidence to say that this is from keyboarding or the like. That being said, I have practiced in California, Ohio, and here, and in each of those 3 states I have seen Labor and Industries or workers' compensation approve treatment for carpal tunnel syndrome based upon work. I don't know what literature they're reviewing. I am more than happy to obviously take care of the problem in any setting, but that just shows you that there's really not a lot known about repetitive use in carpal tunnel. We're still trying to figure it out. I would argue that if you're operating a jackhammer every day, that's probably not good on your median nerve, but keyboarding, I think, could go either way. Again, this is something I wanted to kind of hammer the point home with the pressure within the carpal canal. I would urge each of you, if any of you have early carpal tunnel, even before seeing me, I would go to Target, Walgreens, and get a wrist splint that just keeps your wrist in neutral, and go to sleep with that every night for at least 2 weeks straight. And I'm not a used car salesman, but I will nearly guarantee that you will get some kind of relief from that. And it's dramatic. We talked a little bit about exertional, and now, do you have it? These are the fingers that it affects. Everybody thinks about the thumb and the index finger. The median nerve actually innervates half of the ring finger, which very much confuses a lot of folks who come into the office. They say, yeah, my ring finger, I just don't know about it. Half works, half doesn't work. And the reason being is that's how we're hardwired. Clinical symptoms. When somebody comes to me and the first thing they say is, Doc, it wakes me up at night and I have to shake my hands out. We can talk about the weather now. I mean, you have the diagnosis right there. That is pathognomonic, or basically 1 + 1 = 2, that you have carpal tunnel syndrome, because for whatever reason, you sleep in the fetal position, you sleep like that for long enough, you're going to wake up and want to shake your hand. In our cell phone age, people who are on the phone and use that extremity for talking the entire time develop carpal tunnel. And also when people drive, or if they use motorcycles, that's when the carpal tunnel will come out. And the pain will shoot most likely to the fingertips. So how do I tell in the office? Just like the slide says, listening to you. It's even more important than the physical examination. What tricks do I have? Let's see. So when I get down to the physical examination, I look at your 2-point discrimination. This is one of the easiest ways I've found. And I just came from the office right now. So this is my only torture device, and I tell patients that. Not a mean torture device. It looks kind of like that up there. And I see on your hand, can you discriminate 2 points? Most people at 5 millimeters distance can say, yeah, I feel 2 different discrete points touching my finger. When you get beyond 10, 15, 20 millimeters, that's when the nerves have been damaged to a point where there's either some kind of pressure or diabetes or thyroid disease that's giving you trouble and causing you to have this diminished 2-point discrimination. I'll also test the strength depending on the appearance of your hand, and just look at the hand. These are my secrets. There's another slide, kind of like the medical comorbidities with carpal tunnel, that'll go through about 1,000 different tests. These are the biggies. I gently press on your wrist for a little while. I'll tap on your wrist, and if those two aren't telling me what I need to, then I have you go like this for about 30 seconds where I can catch up with my charting. They're tricks. I'm willing to tell you anything today. So the next step, and I fall into this category, this is a young surgeon's technique, and the reason being is we have obviously a lot more oversight. The American Board of Orthopaedic Surgery, American Society for Surgery of the Hand they're very good organizations, and they keep an eye as young surgeons get older and older. So I am encouraged to use nerve conduction studies. I think most surgeons are. As surgeons will get older, some people will forego this study. There is data out there saying that you don't need a nerve conduction study prior to getting your carpal tunnel release. It's hard to extrapolate to me as an older person, but I still think I would order this because you get valuable information from it. You discover if you have other forms of neuropathy. Are you having other problems? Do you need to be checked for diabetes or thyroid disease? It can also uncover radiculopathy, which is when the nerve is pinched from the neck and goes down to the hand. And are you having any other peripheral nerve disorders? It looks at your ulnar nerve, it looks at your radial nerve, tries to figure out, are you having weakness for another reason? It also nicely gives you a report card and grades. Are you in thin ice? Do you have severe carpal tunnel syndrome, or do you have mild carpal tunnel syndrome? And that helps with the diagnosis for me and also the management. Somebody comes in with severe carpal tunnel syndrome, severe weakness, we may talk about surgery more than bracing, but if somebody has mild carpal tunnel syndrome, maybe that's not the problem. Maybe we may need to do an injection at that point to see if there's some kind of relief, which would lead us to the diagnosis. So again, conservative first. If I can brace you, like I told all of you right now, let's try bracing first. But if you come in with the muscle in your thumb, if you all look at your thumb, we all have a nice beefy muscle down there. If that thumb is sunken in, that's a problem. That means that the nerve hasn't been talking to it for a while, and we need to reintroduce those two folks. So bracing, I like to do it at night. Some people enjoy doing it the day. If you hold the phone to your if you hold the phone to your ear a goodly amount of the day, you may benefit from bracing the majority of the day. As we go on, we can do activity modification. Obviously, if you're using a jackhammer, maybe slow that down a little bit. And injections. Now, injections in the carpal tunnel are similar to the trigger finger, but without the good results, and with the risk of injecting something in an already tight space. We know that when you inject it within the carpal canal, it's very much a team approach. As I give you the injection, I talk to you, I say, are you feeling anything going down the hand? Because we need to get it in there, but not in the nerve. And then the other thing is this wears off. It wears off within 3 to 6 months, and then you're left with carpal tunnel again. Whereas the trigger finger, when you give it an injection, it actually is a solution. It is not just a temporary Band-Aid. So I have mixed feelings about this. If the diagnosis is in question, if you come back, if you have mild carpal tunnel but other problems going on, we may talk about giving an injection as more of a diagnostic and therapeutic tool. Diagnostic meaning if you get better, great, we know it's carpal tunnel, and therapeutic, obviously, if you get better, that's the goal. That's why I'm here. So surgery, much like trigger finger, much like Dupuytren's, is an outpatient surgery. There is a large debate in the literature, and if interested, we can touch base on it with questions later on about open versus endoscopic. The open incision that I use is a very small incision, almost the same size as endoscopic. I use it because where I trained with 8 different hand surgeons. All 8 of them did open carpal tunnel releases, and these were guys at the forefront of hand surgery. There are small risks with endoscopic release, not that it's a bad thing, it's a decision for every surgeon and patient, but there are risks that I don't want to take. So that's my opinion, and it can be argued for literally hours upon hours in a hand surgery forum. The incision, we talked about a little bit before, where is the carpal tunnel? It's a small incision right there. Being completely disclosure full, 80% get complete relief, 10% get partial relief, and 10% get little to no relief. In terms of surgeries, that's one of our better surgeries and how we offer surgery. Now, if you're a diabetic, if you have thyroid disease, if you have some form of cancer, that you're taking chemotherapy that's acting on the nerve, these numbers need to change a little bit, but I still think there is some resolve in releasing that pressure off the nerve. The risks of surgery, obviously the risk of no benefit. There's a very small risk of infection and very small risk of damage to the nerves and the tendons. The other benefits is when we go in and we release the carpal tunnel, you get a report card. I tell you where it was tight. I tell you what the nerve looked like. And in the case of the gentleman about 6 months ago, I tell them that they have gout. I mean, you can find amazing things within the carpal canal. You can find a tumor, not a malignant tumor, but that lipoma that we talked about. So if we can get the pressure off, then it's a very good thing for the nerve. And recovery. The recovery is very quick. Again, we talked about the nerve. Unfortunately, the first thing that comes back is pins and needles. So you realize that you're feeling again. Then that sensation comes back, and finally motor comes back. Now, again, trying to look at pros and cons of endoscopic versus open. The endoscopic surgery, the incision is back here in the wrist, and they slide the endoscope up. My incision is right over the carpal tunnel, and there can be some hypersensitivity, but it's something that's easily overcome with a little bit of massage. Very rarely somebody will need to wear a bicycle glove for a little while after the surgery. And then for those working on manual labor, it's about 4 to 6 weeks to get back. And we talked about scars. All right. And just briefly, the other side, carpal tunnel is obviously a problem that for whatever reason you were predisposed to, so sometimes it can happen on both sides. At that point, it is up to you. There have been studies that show that if you do both sides at the same time, that the overall recovery is faster, but depending on the help at home, sometimes you just want to do one side, get that rehabbed, and then do the other side. There's not a right or wrong answer. All right, what else could it be? Tendonitis. This is the last thing, and we're approaching 45 minutes. I wanted to leave time for questions, so I couldn't do the full tendonitis talk, but as we move along the wrist, right at the base of the thumb here, if you take your thumb, bury it in your palm, and pull down like that, that is a very common test for tendonitis of what's called the first dorsal compartment. You have tendons that go to the base of the thumb and extend the thumb. They go through a tunnel, and that tunnel can be irritated. This is actually very common in postpartum women because what do you do to pick up a baby? You reach down and lift up like that. And with enough of that repetitive motion, you can have irritation there. It sometimes can get fused with carpal tunnel because not only do you get tendonitis and pain, it can cause a little bit of numbness of the nerve that sits right above there, but that nerve is the radial nerve, not the median nerve. So the numbness would be on top of the thumb as opposed to on the undersurface of the thumb. And this, if you can imagine, like the trigger finger, you got a lot of stuff going through a very tight tunnel, and that's what tendonitis is. The ulnar nerve, and I didn't do a full talk on this either because it would be repetitive on the median nerve. So the ulnar nerve goes around the elbow, right about here. It's the funny bone. And that nerve can be angered from sleeping at night with the elbow flexed, or for the same reasons that we don't know the median nerve is at the carpal tunnel. The same results exist. If we release it, we know that things get better. The problem with the ulnar nerve, if you think about a nerve waking back up, it's got to grow. It's got to get to its end point quickly. And quickly is not something that's in the nerve's vocabulary. It grows about 1 inch a month or 1 millimeter a day. And it takes a month for the nerve to realize that it should start growing again. So if you think about the distance from the elbow to the tip of the small finger, that's a lot longer than the wrist to the tip of the index finger. So that's why the results are a little bit more mixed with the ulnar nerve, just because it takes longer to recover. The one last thing I'll touch upon the ulnar nerve is when you move the elbow back and forth, some of us, that ulnar nerve will slip and flap right over the funny bone. If that's the case, then it's a little bit more involved surgery to release it because we need to put the nerve in a new position where it's not snapping like that. That can be very cumbersome and kind of annoying for the nerve. Last thing is these nerves can be pinched up in your neck. I mean, as we get older, we get arthritis. Arthritis happens in the hand, the knee, the elbow, everywhere. It also happens in the neck. And when the nerve is pinched in the neck and in the carpal tunnel, or the ulnar nerve at the elbow, it's what's called double crush phenomenon. It sounds very scary, but it's just more so we can understand how much you can be helped with one or other, with surgery, with bracing. Do you need a neck surgery and a wrist surgery? Let's hope not, but at least it gives us an idea of what's going on. And we talked a little bit about neuropathy, and I always think that's important to keep in the back of your mind because even with the best surgery, with the best bracing, with the best even neck surgeon, that if the nerves are starting at that lower baseline, it's problematic to wake them back up all the way. All right, so just a few take-home points that I think we we did a lot is carpal tunnel is common. And a lot of the time, thank goodness, we can treat it conservatively. So you don't even need me. I think I just lost half of you because I told you to put braces on. Northwest Orthopedics will not be happy with me. And last thing, since we're talking about nerves, don't you hate it when your hand falls asleep and you know it'll be up all night? So, also found literature. So let's take some questions so I can get a break from talking, a little glass of water. That's a good question. And the thumb is a huge culprit, and it's confusing because when you think about trigger finger, the question is, my thumb's popping. Is that trigger or is my joint popping out of socket? When you think about the ring finger, it's going to pop right in here, and it's very easy to do the diagnosis. The thumb doesn't pop down here at this joint. It pops up here at the more distal or far away joint from your body. And when it pops with such severity that people feel, and this is a common complaint, that the thumb is coming out of the socket up there, when really the thumb is getting hung up in this tunnel down here right at the base of the thumb. Now for thumbs, I don't X-ray all trigger fingers because a lot of time the diagnosis is right there in front of us. But with thumbs, I do X-ray because thumbs can have some arthritis that's superimposed. And I think it's important to look and see the arthritis and say, oh, this is really bad arthritis and trigger finger, or oh, your thumb looks fine, it's just trigger finger, let's get it taken care of with that injection. Ah, that's a good question. And actually, my friends from Northwest, they were like, are you going to talk about hand arthritis? Yeah. Oh, I'm sorry. Repeat the question. So the question is, what do you do about arthritis in the fingers? And it's a good question. It deserves a whole nother talk, but I'll try to cover it here in a few seconds. The arthritis of the fingers is something that we don't have all the answers to yet. What I gave you up here with Dupuytren's, trigger finger, and carpal tunnel, very tried and true successful surgeries. When you think about the arthritis in the hands, it's all about anything else in life. It's about real estate. So let's start at the very tip, the end joint. When you get arthritis in this joint, it's normally from osteoarthritis or psoriatic arthritis. And the treatment, if you develop a cyst, is to remove the offending osteophyte or piece of arthritis to decompress the cyst. If it's painful in this end joint, then the treatment is to fuse the end joint of the finger, and you do not lose a lot of function with fusing this end joint here. Okay? Moving back one at this knuckle here. This is the bugaboo. So that's called the PIP, or proximal interphalangeal joint. And when you get arthritis there, it's a big problem because it's a function disruptor. There's two schools of thought. You can replace the joint or you can fuse the joint. For the ulnar 2 digits, or the ring and the small finger, I like to give the patient the option. When you fuse it, it gives you a little bit more strength to those digits. And we get our strength when you think about grip with the 4th and the small finger. The joint replacement is a very big argument. Some of the research I've done when I was back in training, you can either do a resurfacing implant, which is pyrocarbon, which squeaks, and also has sometimes the probability that the bone stock will be windshield wipered away as the implant moves over time. Or you can do a silicone implant in there. The drawback of the silicone implant is it is not inherently stable in what's called radial or ulnar deviation, or deviation in the coronal plane. So if I move my finger these directions here, then the finger is not going to be stabilized by the silicone. I would say the majority of people, including my mentor, would fuse the PIP joint because it gives a more durable solution to the arthritis. When we talk about arthritis in the hand, the indication for surgery is pain. It's not necessarily loss of strength. If it's loss of strength, then we need to think about something else. Yes, it is arthritis. The question is arthritis that makes your hands cramp when you're playing cards. Yes, if you wake up in the morning and your fingers are very stiff, that is most of the time arthritis. It's arthritis when it's hard to get them mobilized. It is trigger finger when that stiffness is accompanied with catching or locking. And that's difficult to kind of tease out. That's something we talk about in the office. Yeah, the painkillers, there's a movement right now with trying to decrease non-steroidal anti-inflammatory, Aleve, ibuprofen, those type of medications, because they can be toxic to your kidneys, and also your stomach doesn't like them too much. Then you think about taking Tylenol, and that hurts your liver. So we're finding more and more that unfortunately there's no free lunch. I think a short course of non-steroidal anti-inflammatories are good for any type of arthritis, but if it's coming to the point where you need to take them every day for weeks at a time, then we need to solve the problem another way. I'm gonna go there. Oh, carpal tunnel. That's a good question. So the question is, one hand, when you go to grip something and then you try to straighten back out, is that arthritis or carpal tunnel? Whenever I get the question, I can't straighten my fingers out all the way, that actually to me is a trigger finger diagnosis. And it's something I look at there. If it's specific to the joints that are giving you trouble, then it's more of an arthritis problem. And sorry, I'm not answering this question right on because it's something I gotta see and know. But if it's a problem gripping the fork, then it's a carpal tunnel problem. Gripping, that fine motion, that where you get it just right, that's nerve to brain. Joints, when you're moving them back and forth and they're just not moving well, that's arthritis. And then when you get the joint down, it just doesn't want to come back, that's trigger finger, even though it's not locking. Cramping the hand, it's a tough one. A lot of the time it's because the hand has been sitting in a certain position for a while, and the tendons normally are quite well lubricated, but as we get older, there's some intertendinous adhesion. So when the hand's been like this for a while and you're like, oh, I need to grab something, and you open it up, that sometimes is a lot of what's called intertendinous adhesions, and that's something that goes away very quickly, and that's something that doesn't even need splinting, that just takes motion. Now, again, excuse me, if it's a popping or a catching as you're trying to grip something, that's your trigger finger diagnosis. And if it's pain as you're trying to open it up, that's your arthritis diagnosis. It's a good question, yes. For neuropathy that is associated with numbness and tingling, the vitamins that have been the culprits are the same vitamins that are taken away when you drink a lot of alcohol. So that is vitamin B and folic acid. So those two vitamins are very important. And some people actually believe that supplementation with vitamin D and folic acid can alleviate some forms of neuropathy. What's that?
I'm sorry, did you say D or B?
B as in boy. Sorry. Yes, I'm going to take one sec just because we're still going with arthritis. And the last joint, when we talk about the hand, is what's called the metacarpal phalangeal joints, or these joints right here. And those are treated in a similar way to the PIP joints, which are up here. It's either a fusion or it's an implant. Both the implants work a lot better at this joint back here than this joint in here. And of course, the last area where we all get arthritis, as common as the knee or as the hip, is at the base of the thumb, which definitely would be another talk. But the nice thing that I can tell you about the base of the thumb and arthritis down there is I treat the majority with injections, and I think a lot of injections work out, and then you avoid the surgery. Out of all the surgeries I do, this is a very successful one when you have arthritis at the base of the thumb. We take out the arthritic bone. On the flip side, though, this is also the one that takes the longest rehab. When we take that bone out, sometimes it takes up to 2 to 3 months before the pain relief really comes to fruition, because taking a bone out of the hand, your body wakes up and you're not too happy with me. I don't get the cookies brought to me until at least 2 to 3 months. Yeah, I'm sorry, no, come there. Yeah, this is why I enjoy my job, because each one, like, it's a different story. Nothing really falls into what we talked about today, but you bring up a good point. Carpal tunnel is not always diagnosed by the nerve conduction studies. You know, it's something that I need to see your hand, I need to kind of press on it, test your 2-point discrimination, and also look at those x-rays. A lot of times what we're finding, you touched on a point, which again will be another talk in hand surgery, where you get that x-ray and your doctor calls you up, and this does happen. I'm not making light of it, but I think it's important that it's not an emergency in the over 50. It's an emergency when somebody's in a car accident. But the two bones, the scaphoid and the lunate, are attached with a ligament, and that ligament is very stout, very important ligament in our hand. When the ligament is broken, the two bones move across. And you guys will at least hopefully know the sign. It's called the Terry Thomas sign. Anybody know who Terry Thomas is? All right, Michael Strahan. We'll go more contemporary. Arnold Schwarzenegger. Some big space in between the teeth. So these two bones move apart, and that signifies that that ligament has been torn. And I have seen, my favorite was this lovely, lovely lady. She was 85, and she called me at home. She was so worried. She said, I got the doctor's report. I haven't seen you yet, but they said that I have a scapholunate injury, and this is a very traumatic injury. I need it fixed right away. And I'm like, well, Mrs. Jones, did you get in a car accident? No. I've just been having some wrist pain for the past 20 years. And I said, okay, we'll see you tomorrow. I promise you it's going to be okay. So These type of problems where the bone splits and you get that space in between the two bones, that can happen traumatically with a huge amount of force. We're talking fall off a bicycle going 40 miles an hour, car accident, fall off a building, and then it needs to be fixed very quickly. And normally it happens in a 20 to 40-year-old active individual. When we see it later on, it's either congenital, meaning some of us just have a bigger space there, or it happened a long time ago and it's nothing urgent. So that call sometimes you will get, and you guys are all welcome. You can call me at home too, and I can. That's the call I don't mind getting because I can easily say it's going to be all right. It's a good question. So the brace, I'm a simple person when it comes to bracing. I'm going to talk as I advance, so if you see the brace, yell at me. The brace for carpal tunnel does not need to go around your thumb. Braces that go around your thumb are more for dequervians, tenosynovitis, which is a tendonitis, or it is for arthritis at the base of the thumb. Those are the two times where I give splints that wrap around the thumb. No, that's a great question. The question was arthritis and thyroid, and that is not something that has an inherent symbiotic relationship. The arthritis and the thyroid, for the most part, are separate. With arthritis at the tip of the index finger, it's normally from the labor that you incurred your whole life. So people who do a lot of pencil pushing, the index finger will deviate towards the small finger. And if you do a lot of heavy gripping, the index finger will deviate away kind of in yours. So I would look at that hand and I would say you worked hard for many years, and that's why the finger's off a little bit. The treatment for that type of problem, again, is the fusion. I would not let any surgeon talk into a joint replacement for that end digit. I think the risks outweigh the benefit in that setting. Yes, you in the back, sir.
How do you differentiate between multiple sclerosis and carpal tunnel?
So the question is, how do you differentiate between multiple sclerosis and carpal tunnel? And that is difficult. That is very difficult. There was an article that I wrote with Dr. Meals, who's an old hand surgeon in California, where we tried to tackle that issue and also differentiating carpal tunnel from things like Lyme disease. And the short answer is you can't. The long answer is you need to determine where the nerve is getting stuck. So is the nerve getting stuck at the wrist? And you do that with some more provocative maneuvers that I would do in the office to try to irritate that nerve right as it crosses the wrist crease. In terms of the multiple sclerosis, that's something that for a true diagnosis these days you need an MRI of the head to look specifically at the consistency of the white and the gray matter. Multiple sclerosis also has an accompanied symptom that is very easy to diagnose. If you see red spots, that can be an associated symptom of multiple sclerosis. So, and the last part of the long answer would be a nerve conduction study, because one of the nice things about nerve conduction studies is it really tries to determine where the traffic jam is for the nerve. They'll put a small acupuncture-like needle here, an acupuncture needle right here. And if it's slowed more than the normal across that setting, then you could have diabetes, thyroid disease, Parkinson's, multiple sclerosis. You can have all of those affecting the nerve, but then you have carpal tunnel on top of that. There was a study in the New England Journal about 6 or 7 years ago now, and there was no difference between taking a sugar pill and taking glucosamine. That being said, I know it's a bummer because it's so well marketed, and we have so many anecdotal stories saying that, my aunt took it and loved it. One of my good friends, he just retired. He worked at the Mayo Clinic for his career. Just a great guy, replaced more hips than I think I could ever do carpal tunnel. He would always tell a patient, go to Costco, because actually, not endorsing Costco, at the time, Costco had the only mixture of chondroitin and glucosamine that was at a decent amount. The problem is this medication, just so you know, is not governed by the FDA. So if you buy Bob's chondroitin glucosamine, it could be 99.9% sugar pill and 1% chondroitin, whereas Costco's brand at least had the material in there. So his recommendation would be go to Costco, buy a bottle, just one bottle, try it out. If it helps you, great. If it doesn't, then get rid of it. You need to make sure that the risks are very much outweighed by the benefits. So when you think about chondroitin, the risks, some people get a little bit of constipation or diarrhea, and that's very rare, so the risks are minimal. So it's just the cost of the medication. When you think about doing the surgery, obviously, before I even think about doing carpal tunnel surgery, I want to make sure I've done everything else I could, because the risks are out there. The risk of infection is there, the risks of a non-healing wound. So, you know, you always want to weigh that in the balance before initiating any therapy. Thank you so much for your attention.